dia. Buenos dias. This is Harvard with both languages, actually 3 languages, Spanish, Portuguese, and English. So I could try to do this in Portuguese, that is true, but Paulo decided that English would be the language. So, but if people have difficulties following what I'm saying, just stop me and we'll come back. We'll try to give you a translation. Thanks for the introduction. Just to say one additional thing. This hub has 2 components. One is the research. Paulo will probably talk a little bit more about that. And the other one is the capacity building component, which is more to do with training people, bringing people into research, mostly into what we're trying to do. And I will try to tell you what is the idea behind this thing. So for those of you who may have an interest in training, so you should approach Paulo here, because there are great opportunities. Okay? So that's the first thing to say. The second thing to say is that the whole idea of this hub is about integrating mental health into general health. As you will see, that's working? No? Can I sing? Is that any better? No?
Yeah.
Yes.
I think you need to put it like the singer. I think it has to go this way, or not? Yeah. Okay. Thanks, Paulo. So the whole idea of this is trying to integrate mental health into general health. And this case because we, all of us, some of us work mostly in mental health, which is my case. You will see, because I'll show you a few examples, not just mental health. Most of my work is actually integrating mental health into general health. Paulo is based in a department that is already integrated, if we can say that. And Jaime comes from cardiology, Jaime. So it's more of a cardiology rather than a mental health. But eventually he'll become a psychiatrist. So that's the idea behind the whole thing. And this comes because of the realization that for a very long time, mental health has been working in isolation. We've not really integrated, and you feel that that has been to the disadvantage of mental health. So that's how we came to this thing. I will give you a little overview of the idea of the sort of things that I'm involved in integrating and what, just a very rough outline, because Paulo will cover what we're trying to do here in São Paulo. Okay. Now, before I go, I will say that I have the privilege to work with several colleagues here in Brazil, not only in São Paulo, mostly in São Paulo, but I work with people in other parts of Brazil, especially in the north of Brazil, and also in Rio. I'm not sure if there is anyone here from the north, but Maria is from Rio. Yeah, I do work with people from Bahia and Recife. Okay, so I had a long love relationship with Brazil. I'm not Brazilian, I'm Chilean originally, born in Chile. But I've been living in England for the last 30 years, or 20-something years. So, having said all of this, let me just tell you why I think mental health has to be integrated with general health. As you will see there, and this has been our slogan for a long time, we believe that there is no health without mental health. Last week I was at a meeting with MPs and senators from the whole of Latin America, all the heads of the health committees from parliaments in Latin America. And it was quite interesting. In fact, there was a small delegation from Brazil led by Senator Humberto Costa. I think Humberto was minister at one point.
Minister of Health.
Yeah, he was minister at one point. Anyway, he was representing Brazil. But then, all the presentations started with saying, there is no life without health. This is not working, it's running out of time. I can shout if it doesn't work. It comes natural to me. Hello? And they started the presentation, which was really nice. I have to tell you that, they started the presentation saying there is no life without health. And then most of them presented the definitions of health. And then, obviously, in all the definitions, there is the mental. So it was very easy to sell the idea of mental health to all the people. And in fact, I have to say that I was surprised by the incredible reception that the idea of mental health had among these people. And some of them really made, especially the hosts in Peru, they made some very interesting, I would say, proposals about what they're planning to do, which I was discussing with them, that is really, it's interesting what is happening in that country. So selling the idea that without the mental aspect there will be no health, it's just, it's just there. The problem is that it has been in the definition for far too long, and we have to say we've been the poor remedy in this definition for far too long. And I believe that partly it is because of our fault. And our fault is that we have an integrated definition, but we have not really integrated ourselves. For some reason, for decades and decades, we've been trying to work our own way. As you will see there is also the social aspect that, interestingly, it was touched, but because the social provides the context to the definition of health, really. So you have these two elements that should be one, the mental and physical, and the social provide the context. So for most of those people, it was that the social determinant of health, which interestingly, it made it really easy to sell the idea that, pretty much the same social determinant that we see for physical health do have an impact on mental health. So things were there to integrate health with physical, mental with physical. Now let me just give you a rough idea of where we are. Now, I hate to use this slide, but we live in a world where resources are finite and we compete for them. And that's the way it is. And I believe that this is one of the reasons why the two things get separated. The mental from the physical. But not only from the physical, because physical illnesses, there is another battle there between communicable diseases, infectious diseases, and non-communicable diseases, which are called physical. So there is a constant, that's how the world is sort of organized. That things have to be separated, and then it's difficult to integrate. So essentially, this is the global burden of disease to 2010. That's the latest one. And these are the results. The reason why I wanted to show you this, because this was another thing that it was very powerful with the MPs, is that when you look at the global burden of disease, the proportion attributed to mental health problems, oh, you gave me a point. I better use it. If I can learn how to do it. Is it the point?
It's very complicated, yes.
Very complicated, huh?
Yeah,
Technology.
to have
We work in technology, by the way.
you might never actually. And then you just, no, it's not.
Oh, don't worry. It was wrong. Thank you, Paulo. Very difficult. So what you can see here is that when you look at the proportion of the global burden of disease, this is globally for the entire world, by the way. You see that mental health problem comes fifth, pretty close from cancer, by the way, and neonatal disorder. Of course, the leading thing is cardiovascular, and that will probably give you an indication what we've chosen to work with one of the cardiovascular diseases. But what really made the difference for us is the level of disability. When you look at disability, mental health problems, I think they're called neuropsychiatric problems in the global burden of disease, they are by far the most disabled problems. So it's not just, and this is something that resonates very well with economy and people who have to make policy decisions. Because we say to them, look, you've got a big problem here. Because these are people who have to live a long life with disability. So there is a price to pay for that. That for them is important. And in fact, when you look at that, there was someone there presenting data from the whole of Latin America about days lost out of work because of health problems. And by far, they were mental health problems. Not only that, someone else also presented data about people who retire because of unhealth grounds. And by far, the majority of them were because of neuropsychiatric problems. So that was really powerful for them. Two really important reasons why they should bet on mental health. Often the problem is, when they come to that, is that they realize that, but they come to us, and I have to say, we failed on that. We failed because now we do have some evidence. They come to us and they say, but what do you have to offer to solve this problem? If you show us that you have something that is effective and cheap and we can afford that, we will do it. But we'll come to that in a few minutes. Now, let me just start by saying, I wanted to sort of show to you that the issue of comorbidity is really key here when it comes to integration. Now, I took the example of two of the most common chronic problems, hypertension and diabetes. And essentially what you see, it's a lot more than just having a mental problem. There are lots of what I would call unhealthy behaviors, like smoking, heavy consumption of alcohol, obesity. And these things are strongly associated with people who have mental disorders. So those are the key risk factors for chronic diseases like hypertension and diabetes. So to begin with, people with mental disorders have an increased risk of this unhealthy behavior, therefore they have probably, even though it's often unnoticed, they probably have higher rates of hypertension and diabetes. For a number of reasons, these people are neglected. Anyway, they're offered treatment, and often they do a lot of work with their treatment. So they are more likely to experience the disorder, they're less likely to adhere to treatment, and therefore, unsurprisingly, their prognosis is a lot worse. So when we talk about mental disorders, and I wanted to make this point, because when you look at the global burden of disease, what you see is the direct burden caused by mental health problems. But there is another burden which is unaccounted for, and that burden comes from the comorbidity. Now, if there are three, this is something that there are lots of problems with mental health services, lots of them. In terms of availability, we don't have enough. In terms of utilization, we are very inefficient. In terms of distribution, there are lots of inequalities. In terms of impact, we haven't been able to prove the effectiveness, although, as I will say in a few minutes, we're a lot better on this one. I'm just going to refer a little bit about these two bypassing. So first of all, the scarcity. So mental health problems, if you want to treat them, the treatment depends very heavily on human resources until now. Okay? This is not, mental health problems are not treated with equipment. They're treated mostly by people. So what you see here as a shape as I've seen who did this slide, what you see is not important. What is important is what you do not see. And what you do not see here, 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 it is resources, human resources in low-income countries. Essentially, there is virtually nothing. These are the high-income countries, and as you can see, the differences are enormous, huge differences. So we start with the problem, and the problem is that we don't have the human resources. This is something I saw in The Economist a few years back, and essentially it was an article saying, you can see here is the doctor, doesn't look very happy actually. It should be a lot happier because I will tell you, there's a lot that can be done that doesn't involve the doctor. But essentially what it's saying is that the doctors are losing the traditional role, and that role is being taken by other people, which is something that we will refer to as task sharing or shifting, which is simply transferring roles to other members of the team, with obviously appropriate training and adequate supervision. But then there is also this, which is emerging very strongly, and that is technology. So technology can also help to not necessarily to replace the doctor, because as I told you, in low-income countries, we don't have the doctor. But essentially, technology can help to occupy the gap that has been created by the lack of this person. So this is the US, okay, a country with a lot more resources than any of the low-income countries. So even in the US, and in the US, this situation, I think, is mostly arising, not entirely, believe it or not, they do have their own problems with human resources, especially in terms of equal distribution of resources. Even in the US, perhaps also because of saving consideration, they are beginning to think about these two options. And the article actually, and I'm going to just simply, three things that I want to say about this. You can all, I'll give you the reference if you want to read the article. It was in 2012. The first thing that for me was very striking is that in the US, people are saying that physician assistants, you know what a physician assistant is? Well, it's essentially a nurse. I think there are a few people here from the US that may correct me if I'm wrong. But it's essentially a nurse who receives additional training and is allowed to act more like a doctor. This person is allowed to prescribe certain medications and so on and so forth. Now, I have to say that I was seen by one of these people at one point because my health insurance cover sent me to one of them, and I was really impressed. You know, very thorough examination, clear diagnosis, treatment explained in very detail. I thought it was high quality service. Second thing to say is that they're saying that the resources are slowly being reallocated. Nurses and other health workers will put the training to better use. Okay, that comes as no surprise to us, because that's exactly what we're saying that we have to do in many of the poorer countries. And finally, devices, which is our third line of work. Devices will bolster care in ways previously unthinkable. Doctors, meanwhile, will devote their skill to the complex task worthy of their highly trained abilities. Can I just ask the audience here if you can raise your hand, all those of you who are doctors? Okay, well, okay, we're in a minority. So it's interesting that, you know, we have people, almost 60% of the audience actually are not doctors. And this is pretty much advocating for that. Now, when we talk about task shifting, how much more do I have? 5 minutes?
That's 10.
10? When we talk about task shifting and task sharing, I want you to be aware that, you know, there is a lot of debate around it. Because people say, you know, some people feel that it comes with dumping duty on other people. And in some places it is really dumping duty. So there are lots of issues that need to be addressed. Some of these people, the non-doctors, as I said, in most low-income countries there are no human resources, full stop. But there are some resources, and most of those resources are non-doctors. Usually you find community health workers, people like that. And everybody, as you would expect, is trying to use the only resource available. So these people have to do the immunization program, they have to do the treatment of HIV, they have to do the antenatal care, and then here you can, you know, that you ask them to do a little bit in terms of the mental health program. So, you know, there is a limit. You can't ask people to do everything. There is a limit. And often you encounter that these people tell you, look, you know, I just can't take no more. So that's one big problem. There are a number of other problems. I would say, I don't want to look at my slide actually, because I've listed in there some of the things that I've encountered. But I would say, second thing, to me, that is a real critical problem, is the lack of reward and recognition for the people who have to step up and do a job. They come, they are the only resource, and we ask them to do more and more and more. And really, what do they get in return? So I think there is a big issue around that that needs to be addressed, and that is a global problem. The third thing I wanted to say, and I'm not going to look at that, I just want to tell you at the top of my head, it is the tension or the power war. That there are lots of people who have vested interest. You see it a lot more in middle-income countries. You would probably, I'm not going to share with you now some of the experiences that we have here in Brazil. We had similar experiences in Chile, same country in Colombia, and so on. It is this thing that people feel threatened, because this involves changing. So the fact that some people encounter stepping into your territories and acting on things that you were used to do, or not do because you didn't have time, it's uncomfortable. It's uncomfortable. So there is a lot of tension in terms of, you know, what is where are the boundaries here? When in reality, what we're trying to advocate is for more of a team approach to problems. Let me just say a couple of things about inequalities and health and in general. And this comes from, this is Chile. There were two national surveys, one in 2003 and one in 2010. I'll tell you why we talked to. So what I want to show you is that, this is depression, hypertension, and diabetes, the prevalence in 2003 and the prevalence in 2010. What I wanted you to concentrate on is on the access. Okay. Now, in 2003, as you can see, these are all people who have been diagnosed with this condition. Okay. So, roughly 60% of the people diagnosed with depression did not get any treatment, and as you can see, 40% for hypertension, 10% for diabetes, roughly. In 2005, Chile introduced a national program which is called AUGE. And AUGE is a program that provides a social guarantee of access to treatment following guidelines within a certain period of time after the diagnosis, that you will be treated for the condition. These three conditions were among the 54 conditions that were introduced in the initial package. So every Chilean, okay, or every, I should say, because not all of them are Chilean, but every person in that country has the right to get treatment for any of these three conditions after 2005. Okay? And it was a right that if it wasn't exercised according to what the law said, you could take the state to court. So, an incredible opportunity for people to get access to all these things. And essentially, this is what happened. And, this is, I get tired of saying these things, politicians like it a lot. Because I say, first lesson of this is that if you offer universal coverage, even for specific conditions, the first thing that you will see is that there will be a tendency for those who were at a lower level to come up at a much higher level. So if you were a politician and you want to sell something that you've achieved, the lower that you start with, the better that you will do in a short period of time. The problem is, how do you improve when you reach this sort of level of access? And as you can see, it was only marginal for hypertension and diabetes because it was already pretty high. So the AUGE program, what it did, it actually, in terms of inequalities across different conditions, it helped a lot to reduce that gap. I'm not going to show you here, but in fact, it did also reduce social inequality hugely. So, universal coverage, no matter what, because there are different theories around that, I'm not going to get into that, but if you want, we can talk later about it. There are people who believe that, universal coverage, at least initially, favored people who are better educated and have more money because they can size quicker any new opportunity. But the reality is that we didn't find that, and it's a recent communication from a group led from Brazil, I think it was led by Cesar Victora, that showed exactly the same for maternal and child health programs. And this, I want to finish with a few things of integration, and I want to start with it from my colleague Asif Rahman in Pakistan. There's been quite a bit of work, in terms of integration, there's been a lot of work on maternal and child health, and I would say more maternal and child, for a number of reasons. Now, what I did is that in Pakistan, they have this, which is the equivalent of community health workers. They're called lady health visitors. I like they call it ladies. In fact, they're actually real ladies. this is a lady, by the way. It's very interesting. I'll tell you about something which is happening. We've just completed another trial in Zimbabwe, and I'll tell you in a minute. But in Zimbabwe, actually in different countries in Africa, you have the community health worker, and a lot of the community health workers are women. I would say the majority. And very often you find that they are kind of middle-aged or even a little bit older. I would say roughly in their 40s, maybe early 50s, most of them. This woman probably is even older than that. So they are the people who are taking on those roles. You know, there's been a lot of discussions around, what is the sort of people that... actually, I've seen your agentes de saúde comunitaria here. I think they are younger than what I see in Africa. Now, the same as with your agentes, in Africa, these people are also members of the community. Most of them live in the area, which is another interesting thing. So what they did is that they trained these women to identify pregnant women that were coming for antenatal care, and if they thought that they would be, in fact, they did identify them during pregnancy, but the entry into the trial, I think it was during the postnatal period. So these lady health visitors have to go and visit every woman who delivers a baby with some frequency. So they get to know them well, and so they train them to identify if these women were distressed, depressed, and to deliver a very simple talking therapy for these women. Now, the results were incredibly good. I would say probably among some of the best. So at 6 months, 77% of the mothers in the intervention group had improved compared to 47% in the usual care. And at 12 months was slightly less than this difference, but still, very large difference. Now, I have to say, we did another trial in Chile for male incubation, slightly different. We did not have home visits. The mothers will come to the clinic. And you probably know about that one, Maria, because I did Brazil. And we did reach this as well at 6 months, 70% recovery. The only problem was that, at 3 months. At 6 months, there was a very gradual, return to where they were before. We can come back to that and give you some of the reasons. Now, this is another project. The reason why I like it is an ongoing pilot in Guatemala. This is the group. Forget about all the white people, the wincas. Not important here. But the important people here are these. The lead people, well, actually this one too, because she's our project coordinator, and belong to this community. These are in an area called Shela in Guatemala. It's a rural area, pretty close to the border with Mexico. And these are called comadronas. Comadronas, there is no such thing here. Yeah? Yeah, but comadronas, let me describe what they do. These are popular midwives. Do you have popular midwives here? Oh yeah? Okay. So these are popular midwives. These are people that belong to the community and receive a very short training, about 4 months, plus 8 months of ongoing supervision. And that's it, they become comadronas. And they deliver 90% of the babies there. So the only thing, what they're really good at is that they know when they should not do something. That's what they're good at. So, I spent quite a lot of time seeing, I couldn't see a delivery, but I would have loved to see them working. But what they're good at is detecting when there is a problem. So, I talked to them and I said, so what do you do if the presentation of the baby is the wrong one? And she said, well, I know that if it doesn't change by this date, like nothing I can do, I call the ambulance. Because all the state is providing for them in support is an ambulance that takes the high-risk mother to the hospital. And the ambulance service works well. It reaches the place within 12 hours. So that's the deal. They do that job, for which they pay very little by the state, but they do get some payment by the people. But people pay them in different ways. First of all, and I want to say first of all, because they told me that, it's recognition. Recognition. So the people in the community say that it's really important. And they come to them, and they thank them, and they will bring eggs, they will, they will look after them. Because it's a valuable resource in the community. So that's what they made it very clear. And then, if you have a nice delivery and the people are grateful and they have needs, then you give them a hen, a chicken, something. And that's the way it works. So these women, actually was her who brought the French woman here, who'd been living in there for 5 years. They came to us and they said, there are lots of problems here in this community. The women become very distressed, there is a lot of violence, family violence, there's a lot of alcoholism, crime. So these women are very distressed. And we think that the children are suffering because the undernutrition and standard growth in the area is very high. So, and she is interested in the nutritional problems of children. So she said, what we want to do is we want to do a little program with them, and so that they can support the women in their community better. And we want to start with all those women, all those mothers who belong to, who have children at high risk of undernutrition. So those were the people that were invited to the group, the women. And so we worked for like almost a year with them, mostly Anne-Marie, trying to design this intervention that fitted with the way they work. So for instance, groups in there are important. People meet in groups, but their groups have to be in circles. The Maya tradition is all circular. And one of the funny things is that this was supported by the Canadians. And the Canadians, there are some here who have experience with it. The Canadians want you to, when you do a project, that you have to show a theory of change. Essentially, that you have to say how things are going to be done, and how things are being kept, that they will be changed. But the theory of change is a linear theory. So the first thing we have, because we work the theory of change with them, and the first thing they said, well, things are not linear. Things are like this. So they drew their own theory of change circular. Circular. Things are circular. There's no way you can explain things in a linear way, that if you do this, this is what is going to happen. No, it doesn't happen that way. Things go like this.
What did the Canadians say?
Huh?
What did the Canadians say?
They accepted. In fact, they were surprised. That, actually, they were pleasantly surprised, I have to say, that some people could come up and challenge the theory, how they approach things, And this came from the roots.
What the Canadians? ¿Quiénes son los canadienses?
The Canadians have the grand challenge in Canada, which is a huge problem. In fact, they're working with a big program here in Brazil called Saving Brains. I don't know if you've been, do you know anything about Saving Brains Brazil? You should look, there's a lot of money there. That is for kind of, but if you're interested in children mental health, you could apply to Saving Brains Brazil. I'm not going to talk about Progravia because I'm going to leave it to Paulo, but this is another integration problem of treating pregnant women with depression. There are several members of the team that work on this here presently in the room. And I'm not going to talk about CONEMO, which is the research project part of LatinMH. I think you will cover that, Paulo? Yeah. In which, as you see, what I just wanted to point out is that in here, it's the task shifting to human resources. When you saw that the economy slide, it is this side of that slide, using less trained or a different kind of health professional to deal with one problem, not a doctor. And this is what I call a blended intervention, in which there is a little bit of that shifting to the nurse, but there is also a lot of technology as well involved. Paulo will show you this, so I will skip it. Finally, I am involved in several, in terms of integration projects in Africa of HIV and mental health. And essentially, I don't want to bother you, but there are several of these. And it's just sort of, they've come to the conclusion. I mean, more people who are HIV positive, more things are changing because the treatment is a lot more effective than it used to be. But they have health problems of different types. And one of the things that is very common is that adherence to treatment is very low. And one of the reasons is because people, among many things, people are not feeling really well, that there is no motivation, they become depressed, and they couldn't be bothered with the treatment. So some of these programs are in terms of improving adherence. So I conclude with this, just saying, this is our idea, this is what we want to do, this is our mission. Integrating mental health services into general health is good for all providers and client consumers. Thank you.